KMCC. I need to keep my job. Don't let my boss fire me. Okay. Okay, thank you. So I'll talk about a case to set the floor for Professor Ferrari to talk about the BVS. He's going to give us an update. I'll start with a clinical case and talk about the technical issue with the BVS. And recently, there is many data and report came about BVS, bioabsorbable scaffold. So I'll talk about a case, two short cases to set the floor for Professor Ferrari to talk, give us the update, the theoretical about it. So my cases, I called it respect the P's. So when we want to use BVS, I think we have to respect this piece, the proper vessel sizing, the preparation of the lesion, and to pay attention to the expansion limit. And I'm going to talk in that in detail here. So for the sizing, if our size, for example, the vessel size is between 2 and 3, we should use the absorb 2.5. It's between 2.5 less than 3.3, we use the size of 3. If it's 3 to less than 3.8, we use 3.5. So this is the size. You have to respect the size here. The second important message, if you're going to use BVS, is to pay attention to the pre-dilatation, okay? So compared to the DES, when you use the drug-eluting stent, we're now emphasizing on the post-dilatation, most important than the pre-dilatation. However, for the BVS, the pre-dilatation is most important, is not forgiven if you forget, and I'll illustrate this to one case. The second thing, if you don't have, you have to have, before you put your stent, you have to have greater than 40% residual stenosis, so not greater than 40%, so you have to have well preparation of the lesion, and this is very important. The last piece is to pay attention to the expansion limits. For example, for other metal stent, we can, for example, 3/0 stent, we can go up to 4 or 5 balloon. However, with the BVS, we are limited with a 0.5 upsize. We cannot go more than that because it's like it's going to fracture on you. So with this, I'll start the two short cases. The first case is a 60-year-old male. He's a smoker, hypertension, presented with 2-month history of chest pain, and has a positive exercise treadmill test. In this areocaudal view, you can see pay attention, this is a ramus, very significant disease in the ramus. It's very significant disease in the ramus. Intermediate. This view show you the LAD is very calcific lesion with a lesion proximal, long lesion in the proximal to mid LAD. This is another view show you the left circumflex. There is a proximal tight lesion angiographically. So, and the right coronary artery here, there is also some non-significant disease proximally. So we have a patient with multivessel disease with symptoms and positive treadmill. We did an FFR to this patient. FFR, the circumflex and the ramus was non-significant. However, and the right was non-significant. However, the most significant lesion was the LAD. So we elected to do, because the long lesion, we elected to go with a 2-stent BVS in the mid to proximal, and 2-stent proximally is a DES stent. So we use the sizing, we respect the P's here. We elected to use 2.5. We did a pre-dilatation, then a post-dilatation with a 3/0. So, and this is the dilatation, and so this is the stent. This is the first stent. And this is the second stent. And this is this is inflation, the stent. And we ended with OCT. All the cases we do BVS, we ended with OCT to assure that proper expansion. And we have ended with a good result, with a good alignment of both stent, the BVS and the S. So, and we have very good result. It's a long lesion. This is the proximal drug-eluting stent. So we respected this 3B, the proper vessel sizing, the preparation of the lesion, and the pay attention to the expansion. And the patient did well, and we have 2 years follow-up, and he's doing very well. I'll go the other extreme. So we have, this is the second case, 60-year-old male. He's diabetic hypertension, and he has ischemic heart disease. He has BCI in the right coronary artery and the left circumflex 1 year ago, and he presented again with 3-month history of exertional chest pain and angina functional 2. This is his right coronary artery. There is a stent here, it's patent. There is some disease not significant, it's non-dominant RCA. This is his LAD. Again, there is a long calcific lesion proximally and mid, same to the first patient. And this is his circumflex. There is a lesion in the left circumflex here, and non-significant. So we did an FFR to the LAD, and the LAD lesion was significant. The RCA, the left circumflex was not significant. So the FFR was negative. Usually in this multi-vessel disease, I like to do the FFR guided, whether we can defer some of the lesion thing. So we did that. We elected here again to use, this is in the first days when we used the BVS. So we did the pre-dilatation, and you can see here there is minimal waste, and this is a 3O up to 16 atmosphere. And then we put the absorb here. This is a 3O, and usually we go to 1-to-1 dilatation, so this here. And we did both dilated with the third B with a 3.5 higher than, but now I ended still with some waste here. So this is the final result here. And I have an OCT. This is after here. So this is the OCT after. Now, what should I do at this time? So elected now at this time, I cannot, absorb. I cannot go with a higher balloon here. Let's accept this result. Angiographically, I'm okay. I know there is some, but let's accept this result. So what I did with the P's, proper vessel sizing, but however, the preparation was not that optimal to this case. So I pay attention to the expansion limit, so I didn't overexpand. So I did the third B. I didn't get 4 or 5. If I have this is a metal stent, I would have the luxury to go with a higher balloon here, but that's what happened. Anyway, 4 days later, he presented to another hospital with acute anterior MI. He received thrombolytic and referred back to us for angiogram. This is 4 hours after. So this is his angiogram after. Thanks God, he's thrombolized, and there is restored the flow here. This is before, but again, you see, so what we did first here, we say let's do an OCT to see what happened. So the stent distally was well deployed. However, the same area is under deployed, the same what we saw before. So this came from the German group. So now if you have malposition here, and after you're not happy, so you can put a metal stent inside the inside the BVS. And so this is what we did with this one. We did another BCI to him. So this is our first run with export, and this is dilatation with 3.5. Still there is a waste. We went with a higher with 3.75, and still there's a waste. No, this is open. Then we put a drug-eluting stent 3O instead of the stent, and we both dilated higher. And this is the final result after this dilatation. I'll show you the most impressive is the OCT. This is the OCT I showed you earlier, and this is the OCT after. This is the same area, and you can see double layer. You see the BVS stent and the DS stent overlap here. So my take-home message from these two cases that if you decided to use the BVS, I think, my own opinion, you have to respect the proper vessel sizing, the good preparation of the lesion, because it's not going to forgive you if you end it with undeployed BVS. So this is not going to forgive you, and pay attention to the expansion because you are limited only to 0.5. So I think you have to respect this. If you're having this with the DS, you can use a higher balloon, but with this one, you cannot. Thank you.